Those out in video land hear me okay? I see heads shaking up and down, and so welcome to our Texas Child Mental Health Care Consortium Executive Committee meeting. I hope you all had a good, safe Thanksgiving holiday, and it's great to see you today. Why don't we go ahead and do the official roll call? Let's do that, and then we'll get started.
Okay, Dr. Amador. Dr. Babato.
Here.
Dr. Chapa. Dr. Lucas.
Here.
Dr. Farmer.
Here.
Dr. Goodman.
Yes, yeah.
Dr. Goodman.
Here.
Dr. Ibrahim.
Here.
Trina Ida. Trina.
Can y'all hear me? Sorry, can y'all hear me?
Yes, thank you.
Okay.
Full
Present.
council. Thank you.
Here.
E. Johnson. Dr. Keller.
Andy's got a conflict in DC today.
Dr. Kemp. Dr. Linky.
Present.
Dr. Martin. Dr. Martin. Dr. Martin, do you hear us?
Say Dr. Martin. I'm here.
Yes. Thanks. Dr. Martinez. Dr. Matthews.
Here.
Dr. Maxwell. Elizabeth Mayer.
I'm here.
Dr. Nemiroff.
Here.
Dr. Brittany Nichols. Brittany. Brittany Nichols. Brittany Nichols. Dr. Oliphant.
Hello, here.
I'm here.
Dr. Oliveira.
I'm here.
Dr. Bliscoe.
Steve is going to be running late today.
Dr. Cloak.
Present.
Dr. Raji.
I'm here.
Olga Rodriguez.
Here.
Dr. Schussler. Sue Shell. John Scott. Dr. Suarez. Luann Southern.
Present.
Dr. Thompson? Dr. Wagner?
Here.
Dr. Wakefield?
Here.
Dr. Williams?
Here.
We have Brittany? Brittany Nichols? Brittany is here. We can see her, but she can't hear us, so we'll try to contact her. Brittany, do you hear us?
Right, so we have 24 individuals, it looks like a couple are having trouble hearing us. But again, thank you for your time. We have quorum, so we'll officially get started. We have a full agenda. We'll move through it as quickly as we can. That does a lot of important things that we need to discuss with you today. So with that first item, I asked before I do that, a couple of housekeeping issues. One, just a reminder to everybody, although we're very accustomed to the chat function in Zoom meetings, we can't use this, that function during this meeting because this is an open meeting. If you do use the chat function, again, you unfortunately have to hear me read everything you say in the chat in order to be compliant with the Open Meetings Act. So in order to avoid that, I would encourage you again not to use the chat function. Second, please use your cameras as much as possible. Understand that sometimes you have to sneeze or something else. And so for my friends out there that I know that are not feeling great right now, but still are troopers and participating, I understand you have to take your camera off for a little bit because you don't want to sneeze in front of everybody. But again, I would encourage you as much as possible to keep your cameras on. With that, I think we're ready to go ahead and officially get started. First item of business, I need to have a motion to approve the minutes from the last meeting and a second, so that we can go ahead and move forward. Take a second to look at that and I'll take a motion.
So moved.
So moved from Dr. Ibrahim.
Second.
Second from Dr. Roche. Is that a second or a question?
Second.
Second, very good. Any further discussion? Hearing none, all in favor, signify by saying aye.
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 Opposed, nay. Anybody abstain? Hearing none, let the record show we had unanimous approval of the meeting minutes from last month. With that, first item that we're going to do is there's a lot that's taking place right now at the state and federal level related to health policy, related to mental health. And so we're fortunate to have Nelson Jaron and John Snook from the Meadows Mental Health Policy Institute. They have their finger on the pulse of all those things that are taking place. And we've asked them just to come and share from their perspective, the major things that are going on related to mental health policy and legislation for the last session and at the federal level. And so with that, Nelson, I'll turn it over to you and let you manage this part of the presentation.
Perfect. Thank you, Dr. Lake. You can go on to the next slide there. And the next slide. Looks a little blurry for me. Is it? Okay, there it goes. Thank you. I'm going to be providing the state update, and then John Snook, our Chief Policy Officer, will give you the latest on what's going on in DC as they reach the end of the year there. But we've used this slide over the years for the state legislative update, and this shows the total appropriations that have been invested by the Texas legislature over the last decade. Senator Nelson, when she became chair of Senate Finance about a decade ago, she included something in the budget. It's known as the statewide behavioral health coordinated expenditures rider. So she basically wanted to ask the answer to the question of how much the state was investing in behavioral health, which agencies that was going to, and be able to track that information over time. And so that's what you see in this second column here, Behavioral Health Budget GAA. That's the General Appropriations Act. So that's the total funding increase in behavioral health over the last decade. And if we look at the 2025 session that we just concluded in early June, there was $10.41 billion appropriated across 30 different state agencies for behavioral health. Now, that includes the appropriations through the Higher Education Coordinating Board that come to the consortium. And if you look back to 2023, that's about $1 billion increase since the last legislative session. And the key is that is ongoing programmatic and other expenditures that provide for services. It generally doesn't include any one-time funds. One-time funds would be in the third column there, the supplemental budget funding, and most of that over the last decade has been one-time appropriations through our supplemental budget for increased state hospital and other psychiatric bed capacity across the state. So if you look at the 2023 line there, 2.26 billion, but roughly 2.2 billion of that went to 17 unique construction projects across the state. This session, I'll go into the supplemental funding, but right at 215 million. So you see that that's normalized. That 2.26 billion was definitely an outlier. So when you look at the 2025 session, the ongoing funding provided plus that money through the supplemental budget and deeper that we'll talk about in just a minute, which I'm sure most of you are familiar about, that puts the total combined funding at 11.23 billion that the legislature appropriated toward behavioral health this legislative session. But key again is that ongoing GAA cost at 10.41 billion, and that's nearly a 70% increase over the last decade, nearly $4 billion in ongoing expenditures. Go to the next slide here. Some of you attended the Chairs of Psychiatry meeting a few weeks ago, so a lot of this will be the same, but I'm trying to tailor this more towards highlighting items in the children's space as well. So that's what I did on this slide with the highlighting here. So this looks back, the legislature has invested in a number of different grant programs over the years that target particular populations. They did that and put additional funding through a bunch of these grant programs in the 2023 session. But it took a lot of time for those procurements to get out in 2023 and 2024 and for contracts to be executed. So the key takeaway from this slide is that all of those grant programs and different funding sources have all been fully funded for the biennium. So many of the medical schools are recipients through some of these grant programs. When HHSC does the procurement through these, they generally reserve the right to extend those contracts for up to 5 fiscal years, contingent on continued appropriations. So the legislature continued those appropriations for the next 2 fiscal years this biennium, so for 26 and 27. But let's talk about a few things specifically in our space for the consortium's purposes. The Rider 52 needs and capacity assessment that came out in July 2023, I've highlighted this because there was funding that was given out specifically for things that are in the children's continuum of care spectrum. So children's crisis respite was funded through there, as well as coordinated specialty care, some increased capacity for first episode of psychosis. Multisystemic therapy, there was 15 new teams funded through the Rider 52 needs and capacity assessment. And finally, youth crisis outreach teams, which I'll go into in another slide in just a minute. Community mental health grant program, that's a grant program that does state dollars matched with local dollars for both governmental entities and nonprofits. And that can be either for adults or children's services. So there's different children's services grants that went out through that. And then finally, the Smart Innovation Grant Program, that was a brand new grant program in the 2023 session, specifically for children and youth. And so all of that funding was re-upped this session. So there's nearly 30 million again this biennium going to children and adolescent services. So when I was thinking through this, I was just thinking of the different programs that the consortiums has and each of the HRIs have in their regions, and thinking about how it'd be good for them to have a mapping of the different types of programs that are in their regions that have been awarded through these, as you're thinking about different referral services or continuum of care. And different gaps that when you are looking for a kid in your programs here. So I have some of these awards. I don't have all of the information. I'll talk about YCOT. We know where the MST teams are, but children's crisis, yes, respite, coordinated specialty care. I don't have where those new ones have been. And the community mental health grant program, again, that can go to adults or children. So just highlighting those children's services. I'm sure we could work with HHSC to map those out. I do have a list of the Smart Innovation Grant programs as well, but to have a mapping of the different programs out there, the providers, and where they're located at, where they're providing those services, to think about that as part of the continuum for each of our regional hubs. Next slide here. Specifically, the Youth Crisis Outreach Teams, or the YCOTs, that was mentioned in the Rider 52 Needs and Capacity Assessment. The 2023 session, the legislature provided $14 million total for that. There was 11 different communities that applied for Youth Crisis Outreach Teams, and this map to the right shows the 8 that were awarded. Youth Crisis Outreach Teams are a best practice model that did not exist in Texas before this funding. Connecticut has these that cover the state statewide. There's also some in Oklahoma. Milwaukee has a best practice team there, but it's similar to an MCOT, but they're staffed by children and youth facing at a much higher level. And they also do follow-up care. So the idea is to address children's and youth crisis level needs in the communities, help work with their families to stabilize them, and to prevent the child from ending up in a crisis situation, either in an ER or having a placement breakdown that ends up in DFPS. So this legislative session, the legislature added $40 million additional to the YCOTs. So in order to raise the level of funding for those 8 additional YCOTs, as well as provide funding for 8 additional YCOT teams. Those YCOT teams, they're still working on the contracts at HHSC for that to get those finalized, but they're targeting the higher population centers for that. So working our way backwards from Harris County is the most populous county in the state to other high-level population counties, and trying to get those up and going after the first of in the first quarter or March or so of next year. That I think is something as well to build connections with those YCOT teams between our consortium hubs, and to think about how that can be incorporated moving forward. Next slide here. Mental health workforce, a few things on this. There was a bill refiled this session, House Bill 1716 by Representative Darby and Senate Bill 469 by Senator Sparks. It was a bill that had previously been filed in the 2023 session, but unfortunately didn't make it through the Senate. Same thing happened this time. So I think it'll be back for a third time in 2027. But it would authorize Medicaid reimbursement for LPC associates, LMFT associates, and LMSWs while they're undergoing their clinical supervision hours. But so that one unfortunately did not pass, but would have helped with them getting their full clinical supervision hours and their full-blown licensure. The budget this session provides $28 million for the loan repayment program for mental health professionals. Senate Bill 646 by Senator West expanded the eligibility for the professionals for that repayment program to LPC associates, LMFT associates, LMSWs, and certain school counselors. That is administered through the Higher Education Coordinating Board, and there is a website dedicated to that. Right now, they're anticipating on the website, they say that December, that'll be open for application period, but that just expanded the eligibility. It is still eligible for all other mental health professionals. So psychologists, psychiatrists, counselors, social workers, chemical dependency counselors, they're all eligible professions. So if you have anybody that may be interested in that, tell them to keep an eye on the coordinating board website for when that one goes live. The budget also provided $5 million for the Behavioral Health Innovation Grant Program, which was a grant program created in the 2023 session, House Bill 400. The idea is to provide funding out to our universities and community colleges to create new programs or expand capacity for programs that can train and graduate more mental health professionals. This $5 million was specifically set aside in the budget for community colleges. So looking at new associate's degree programs and certificate programs there to expand the mental health workforce. And finally, just a quick note on licensure compacts. The state of Texas is already a member of the Interstate Medical Licensure Compact and the PSI Compact. We are not a member of the Social Workers Compact or Counseling Compact. Both those bills were filed in the House and Senate, and neither one, unfortunately, had a hearing this session. So still not a member for the social workers or the counselors. Next slide. A few slides left here, and I'll turn it over to John Snook. State hospital redesign, I mentioned at the beginning, those one-time fundings. The legislature, since they started investing in new state hospitals and inpatient capacity since 2017, has put more than $3.6 billion to new construction. This session would have been the 5th legislative session, I think, or maybe 5th, going towards additional investments. And it looked like at one point the House was behind that. The supplemental bill that they passed out of the House had planning dollars in it for a new hospital in Brazoria County, as well as one in Tarrant County. But the final version of House Bill 500, the supplemental, removed all of that and instead focused on investing in the buildings we already have. So for the first time since 2017, there is no dollars out there for planning to build any state hospitals. So I don't think that will keep anybody from coming back in 2027 and trying to ask for a new state hospital or inpatient project in their catchment area. But I do think that this is probably the end of the investments. And the reason for that is because, one, they're turning to protecting the investments, so reinvesting in the buildings that have already been built and investing in staffing the new builds that are coming online, which I'll get into the next slide here. But ultimately, House Bill 500 provided $12.9 million to the Harris County Psychiatric Center for renovations there. They provided $98 million for deferred maintenance at our state hospitals and state supported living centers. So again, protecting the investment that's already there. And the original $50 million that was given to El Paso for planning and land acquisition for a new hospital in El Paso, they instead repurposed that funding, and they're working with Emergence Health Network out there to create a new East Side behavioral health campus in El Paso that's going to have crisis facilities, crisis stabilization units, some EOUs. It will include 8 beds for youth out there. So for Dr. Martin and Texas Tech El Paso, something out in your area there, but that is with Emergence, the local mental health authority there. And next slide. I talked about the shift to operations funding, and that's really what the legislature is focused on now. With those $3.6 billion in investments since 2017, some hospitals have already come online, like the new Austin State Hospital or the San Antonio State Hospital, that were replacements. But the big deal is all of these new projects in areas of the state that never had a hospital before. So the legislature is on the hook for hundreds of millions of dollars to now operate those builds on an ongoing basis. So when we talk about the $1 billion increase in ongoing funding through the budget this session, 400 million plus of that was just to staff beds that are coming online. And that's going to happen for the next 2 legislative sessions because of the number of projects that are out there currently under construction. They're going to be staggered over the next 4 to 6 years when they come online. And so that's going to be an ongoing expense that's going to be added on to that 400 plus million each legislative session for the next 2 sessions. So it's going to be a huge amount of money. But this highlights a few of those. The legislature has done this in a few different ways. They've added money to state hospital projects. Those are HHSC FTEs or state employees. So they've added money to our different state hospitals to expand capacity there, as well as some dollars on the front end to staff new builds that are expected to come online next biennium. So that's what you see in this first bullet here, Lubbock and Amarillo, new builds there. They also have the new Dallas State Hospital that originally we were thinking UT Southwestern was going to operate. There was $114.2 million to start that up in 2026 and fund that through 2027. That is now, because of the budget rider, it went out through an opportunity for people to reply through what's called a request for information, which I believe UT Southwestern did apply, but the Legislative Budget Board of the state, they have to make a decision by April 1st about who's going to operate the Dallas hospital. Is it going to be an HHSC state operated facility, or based on the information they received from the request for information, are they going to contract out with UT Southwestern or another provider to operate that? The last 2 bullet points here are non-state operated facilities. So they added $93 million for rate increases and expanded capacity at community mental health hospitals. So that's contracting out with private or public providers out in the community, like the new Uvalde Behavioral Health Campus. Uvalde Behavioral Health Campus is a new 32-bed facility out in Uvalde. It's got 16 crisis beds for adults, 16 crisis beds for kids, and it's going to be operated by Hill Country, the local mental health authority out there. So that's a community-operated facility, just like the Comal County one, the 16-bed EOU and crisis residential facility that's going to open up in Comal County. And so I am going to pause here just for a minute, and I do want to highlight this because while a lot of these new beds have gone to adults because it was by and large driven by the increase in the forensic wait list, most of these beds or builds have a percentage set aside where they have to have a minimum number of those beds dedicated to forensics. There are beds across these that are going to be for children and adolescents as well. So I mentioned that Uvalde has those 16 crisis beds for youth. Dallas, because of the donation of Children's Health up there, is going to have 92 beds for children's and adolescents up there. So it's 292 beds total, 200 for adults, 92 for children and adolescents. Terrell State Hospital is being rebuilt. The new Terrell State Hospital is slated to have 50 adolescent beds. Wichita Falls Hospital is also being rebuilt. That one's slated to have 25 adolescent beds. Amarillo is expected to have a few, and I mentioned the new behavioral health campus in East El Paso, 8 crisis beds out there for kids through emergence as well. So by and large, again, the capacity is going to adults and it's heavily weighted towards forensics, but there are pockets of children's and adolescents beds and a lot of these new beds that are funded across the state. Next slide here, which I think is my last. DPRIT, I think most everybody here is familiar and excited about DPRIT, but just wanted to hit this quickly. The Dementia Prevention Research Institute, which is modeled after CPRIT. This was one of the Lieutenant Governor's top legislative priorities this session. It passed as Senate Bill 5, which Senator Huffman carried, but it's going to expedite research for dementia, Alzheimer's prevention, or Parkinson's and related disorders, and basically take the same model as CPRIT to invest in research and prevention, to bring research and teams from other states here, and to accelerate treatment and scientific breakthroughs. And the good news is this went through as a proposition. We had 17 propositions on the ballot in November before voters. All of them passed, including DPRIT. DPRIT passed with a 69% vote, and that authorized $3 billion in investments over 10 years, or $300 million a fiscal year. The key thing that's happened with this in the last few weeks is there was a lawsuit filed against DPRIT. It was supposed to go into effect December 1st. But there's a lawsuit alleging that the voting machines were not accurate and it passed because of voter fraud. The people that filed this have filed similar lawsuits in the past and been unsuccessful. So I expect this will be the same, but it is going to delay the start of DPRIT. The next step was that the governor, lieutenant governor, and speaker of the House all had to appoint 3 appointments to an oversight committee at DPRIT. And because the legislation cannot go in effect today because of that lawsuit, I expect that those nominations are going to be delayed a bit, as well as the first $300 million tranche of funds that would be pushed out next year that HRIs and others can apply to. So we'll keep you posted on when that is resolved and moves through the system here. With that, I think we're going to transition over to John Snook and a quick federal update here, and happy to take questions at the end if we have time.
Thanks, Nelson. And I will run through here quickly. Thank you for switching slides. So I think the first big component that's important to cover is the shifts that we saw in Medicaid, the passage in the summer of the One Big Beautiful Bill Act, particularly the changes that we saw, I think, are particularly complicated because they sort of returned the process to a very federalized system. And so changes that you may be hearing about that are impacting some states will not have as big an impact on Texas, while other components of the bill are likely to have a broader impact on Texas. So that's one of the more complicated components of some of the things we're seeing at the federal level, is just a lot of confusion and misunderstanding of what is happening in different components. Particularly for Texas, the biggest changes that we are likely to see are related to the provider taxes and state-directed payment cuts. And we could talk about that on the next slide. But for the majority of states, the conversations about individuals losing coverage and remaining uninsured, oftentimes those estimates are analyzing changes that are happening to work requirements. And Texas is one of 8 states that, because of the lack of Medicaid expansion, those changes will not be impacting our population in the same way. And so there obviously will be changes to the system. There are some significant reductions and new requirements of the state to do new analysis and do new coverage, but the specific changes that you may be seeing talked about quite a lot in the news right now aren't impacting Texas in the same way. And so if we go to the next slide, these are the pieces that are specifically going to be impacting Texas. Now, the first is the increase in eligibility analyses. This is a significant new requirement for the state because the state is now required to do much more rigorous and much more frequent checks of Medicaid eligibility. Now, in a state like Texas, there was already a robust system for doing that. So the impact will not likely be as extensive as you may see in some other states on the news, where this is sort of a brand new process. There are predicted to be a significant level of churn and a significant level of confusion. They had the Medicaid Directors Conference last week, which we attended, and there was a significant conversation there about concerns with regards to technology and the ability to sort of implement the requirements in an effective way. Obviously, the most impactful there is the Medicaid, the frailty component, which is the sort of work requirement exception that is impacting mental health. Again, that is not something that will impact Texas. There's a lot of confusion around that just because so many states that is a significant impact, but that provision will not go into effect in Texas because we don't have the provisions that sort of trigger it. The two that are expected to be significant impacts on Texas are the changes that are happening to both the provider taxes and the state-directed payments. Now, these are provisions, and I won't dive too far into the details, but these are provisions that are basically implemented and allowed to increase the rates and the funding that is available in state. The federal government has added new restrictions and freezes to how those requirements will be utilized going forward. So starting in 2028, states are prohibited from establishing new provider taxes or increasing the rates of existing, and there is a phase down period which also ends in 2028. Then for our state directed payments, the SDPs, those are also going to be subject to new federal limits. The most important one is that those will be set at 110% of the Medicare payment rate for non-expansion states like Texas. Again, that is expected in 2028. And I say expected because there is a significant conversation happening in DC right now that's saying that the impact of these may be too much for members of Congress to stomach, and that there may be some provisions that look to freeze these or extend the timeline for when they go into effect. That obviously isn't something that can be planned on because the process is still ongoing and things are obviously moving quite quickly in DC. There's a lot of question about what's going to happen. But that is a conversation that's happening right now. But if nothing changes, 2028 would be the timeline for those. And then, as you all are most likely aware, the Rural Health Transformation Fund, this is a very significant fund, $50 billion for states to do a whole host of things to address the needs of rural health. Again, happy to talk about this in the question part or to go into more detail if necessary. I assume most of the folks on the call are familiar with the process and familiar with Texas's application and the significant opportunities that presents for communities. Going on to the next slide. As we said, this is really the big moving part that we're not yet aware of, is when some of these things are going to actually be felt on the ground. With 2028 being the timeline for many of these, the process is going to change. And one of the hard things for many in the public and providers who may not be sort of in the weeds day to day is things will go into effect at different times in different states, and the process is going to be very complicated. I think for lots of people on the ground not understanding if their Medicaid has changed or if their personal health care is somehow impacted by the changes that are happening. And so that's a big concern that we're hearing from Medicaid directors around the country, is just that level of confusion and churn just because of the process complexities. If we go on to the next slide, we'll see some of those timelines that we were talking about. So the most important here, and we'll talk about it in a moment, is the enhanced premium care subsidies, which were not extended in this bill. And those obviously will be ending here at the end of the month. And we'll talk about that in a moment. Um, but again, the majority of these changes that we are really concerned about in Texas are 2028 changes. The other components, the start of these processes, typically are impacting the expansion population states. And those are states that expanded Medicaid, so they do not impact Texas in the same way. And if we go on to the next slide, this is really where we are seeing a lot of the conversation in DC right now. The ACA subsidies expiring. These are the subsidies that reduce the costs that people experience when buying Affordable Care Act in health insurance from the marketplace. Texas is currently the biggest utilizer of this program. So more people in Texas receive their health insurance through those marketplaces than any other state. Florida is a close second, and depending on if you want to go per capita, et cetera, there are some other states that are close, but Texas is a huge user of that program. And so the expiration of those subsidies, which is the subject of obviously huge debate right now in DC, will have a significant impact on Texas. And that conversation, I don't think anybody can tell you where it's going to go. And so I hesitate to predict anything beyond saying that is something to be paying attention to, because that will have a significant impact on the process throughout Texas because so many people leverage that. The deadlines, the important deadlines that we are dealing with here is the continuing resolution that ended the shutdown that many of you are most likely aware of, kicked that timeline to January 30th. And so we are now in a process where Congress is working on appropriations bills. They are working on trying to get all of those done and the Affordable Care Subsidy decisions made by January 30th. If they aren't able to make those decisions, we would go back into another shutdown. The Democrats have signaled that there may be some willingness to do that if they don't get what they want on the subsidy expiration. Obviously, President Trump has weighed in a number of times over the Thanksgiving holiday, talking about his ideas for what a subsidy change should look like. And both the House and Senate are working on their bills. And at the same time, the appropriations process is going on as well. And so all of those are going to come together in January to try to figure out what the process is going to look like. And if if a decision isn't able to be made, we would fall into, again, another shutdown. So there are two basic ways out of that. The Senate could pass appropriations language that the House would then take up, and that would finalize the typical sort of appropriations process that's happened every year in Congress. That is increasingly seeming unlikely, and so we may end up in what's known as another continuing resolution process. And that's where we basically take the budget that has already been passed, which is now something like 3.5 years old, and utilize that for another year. The president has made it clear that he does not want to have another continuing resolution and go down that road, but that's maybe where we end up. And in that process, the conversation about the subsidy would likely come up. So there is a conversation that is the potential for a continuing resolution to be passed for a short period of time to give more time to work on that ACA subsidy, to figure out some new strategy for solution there. But at the end of the day, what we're likely to see is a lot of confusion, a lot of back and forth over December and January, and then most likely ending with a long-term continuing resolution that includes some provisions in there to extend the subsidy for a year to allow both parties to sort of continue negotiation and to work on that going forward. And so We'll have to stay tuned. That obviously is assuming a huge number of things, but that's the process as it stands. The one additional piece that I would flag is that that process will allow for an additional conversation about extensions of important healthcare provisions. Some of those that I think are very relevant to this group is the telehealth extensions, the Medicare flexibility that was provided during COVID that allows for telehealth extensions and flexibilities has been renewed, but it has only been renewed again as a short period, would go out of effect again in January 30th, and so that would need to be extended. So there's hope that as this process is done, there'll also be a package of so-called healthcare extenders that would include the telehealth extensions and a number of others. And that process also is ongoing right now in the midst of these other two. So I recognize that's a lot. I wanted to make sure we covered as much as possible in the short period of time. I think now that's my last slide. So if we want to turn it over to questions or move forward.
Very good. Thanks, John, and thanks, Nelson. We have about 10 minutes for any questions from anybody on the executive committee. If you have a question, please raise your hand. Don't see any hands raised yet, but again, Nelson, I'm always impressed by the significant increase over the last 10 years. And I would say it probably predated that. You know, we have better data after Senator Nelson's bill, but starting back in 2007 or so, all the crisis services that were put into place, et cetera, and it's been a significant investment from the Texas legislature.
Yeah, it has. That's just the point. We can start doing the apples to apples comparison, but the investments even began in the 2013 session, building up crisis services after the Sandy Hook Elementary School shooting in December of 2012, and trying to protect it after when we had a $28 billion or so shortfall after the recession, trying to protect the mental health investments there. So yeah, we do at least have the apples to apples comparison now. It's easy to see that in a budget and track it over session.
Logan?
Hi there, Nelson. Quick question for you. Over the years, there's been kind of discussion about what numbers are included or excluded in that mental health number. Are the Medicaid mental health numbers in there?
Yeah, that was the column on the left, specifically the Medicaid portion of it. So that was Senator Nelson's huge frustration at the beginning because we were before the reorganization of HHSC and dishes. They weren't looking at that. And so now they're able to track the Medicaid expenditures as well. I think the baseline was $3 billion back in 2015. And so they do track that over time for behavioral health and Medicaid. So that's all included in that 11 plus billion total number there.
Thank you.
Yeah.
Any other questions? All right, seeing none, again, thank you both for presenting and getting also for keeping your pulse, your finger on the pulse of all these changes that are taking place and letting us know so we can adjust accordingly. You can stay with us. We're going to have a similar conversation as we go through some of the things that were particular for the consortium, some update on the bills that we're involved in the budget for the consortium. So I think this is a good transition, and I will let Rachel run the show related to the direct bills that impact the Texas Child Mental Health Care Consortium.
Sound like good morning, everyone. Just a quick update on the bills that we're implementing this biennium. HB 18, which expands CPAN and PRAPAN to rural hospitals and also requires the consortium to implement a TChat-like pilot in a rural hospital setting. We formed a planning work group a number of months ago, and that group continues to meet monthly. Thanks to all you who are participating. An initial evaluation plan has been developed. Thank you, David Lynch. And we just formed a small group to identify use cases to help us define scope and processes for these expansions. HB 6, which requires us to post the list of providers we refer to and the profits for vetting those providers. as well as, providing, additional data, to the legislature in our biennial report. Quick updates here. So, an updated list, of those providers we refer to for, the first quarter of FY 26 is scheduled to be posted today. Ashley is preparing a policy to outline expectations for adding and reviewing providers in any of the system we use to house that list of providers. And we're going to introduce that to the EC in the next couple of months. Caution has submitted a change order with trades to help us gather that additional data that was requested to be included in our biennial report. And finally, the TChat billing rider, which requires us to explore third-party reimbursement for the TNT chat sessions above the initial 4 sessions. We'll be working with a consultant to help us gather data and prepare a report on that. Any questions?
Hearing none, thank you, Rachel. Thanks for all the hard work that put all those things in place. Alex, let's go to you next, related to the budget update.
Thank you. Good morning, everybody. So last week I sent out some. Morning, everybody. Last week I sent out the FY 26 budget and reporting guidance to hopefully give us more guidance as we end our ARPA award on August 31, 2026. Please be sure to be working with your invoicing team to stay up on your invoicing. It's really important that we get our invoices in. And if you are also working on any transfers, that you make those happen as soon as possible. Please reach out to me and our UT Austin fiscal manager if you have any questions about that. Also, as I stated in the budget guidance, we are working with FY 24-25 PR that was unexpended. We had it briefly estimated having access to $87.4 million of GR for our use in FY 26-27. Based on what's been returned so far by the HRS, we have $8.7 million less than that. So we have $78.7 million in GR available. That means that your TChat budget will be directly impacted by that shortfall. So that also means that your FY 27 budget will be directly dependent on your FY 26 spend. As we go through the fiscal year, we can talk more about that. We, of course, will address it again during your budget meetings that we'll have probably early next summer or spring. Once we do the FY 27 rebudgeting exercise, and we also do our draft FY 28-29 budget request. Any questions?
Again, any questions for folks? Really do appreciate, again, all the work that you're doing at your campuses, returning the dollars, that the dollars that have been returned are essential for us to be able to meet our budget obligations for the next biennium. And the whole less was returned than we thought. That's why we just need to be careful with how we spend the dollars over the next year. I think in the end, we're going to be fine, but we just need to be careful and manage our the budgets. And especially as we look at other school districts that may come on board and the chances to grow and TChat. Need to make sure every dollar that's allocated to the TChat program is used for TChat in a wise way. Any other comments or questions?
Hey,
Thanks,
I'm sorry to interrupt, but this is Sue Shell. I wanted to let you know I joined about 10:15. Thank you.
All right, very good. Is there anyone else that has joined us since we started the meeting?
Jair Soares here. I joined about 20 minutes ago.
All right, very good. Anybody else?
Yes, this is Dr. Diana Chapa. I joined about 10 minutes ago.
Anybody else want to let us know that you've been able to join us? Hearing none, let's move forward to the update on our communications. And Melanie, I think I saw you earlier. Turn over the podium to you.
Hello, everybody. Let's see. Okay, great. Thank you. I'm Melanie Susswine. I work with the Center for Health Communication, and we provide communication strategy and support to the consortium, mainly with CPAN, PeriPAN, and TChat. And I'm just going to spend a few minutes letting you know what we have been up to today, so far this year, and what our priorities are this year. Thank you. So, first thing I'll talk about is a little bit about our priorities. One of the things of those priorities is the website, which I'm going to talk about for a moment, and then a few other areas. Thank you. So what we're working on this project year is we're focusing on rebuilding the consortium website. So this is a reorganization for clarity. This is not really taking away content. It's repurposing it, moving it, making it look more inviting and reducing some of the text on pages and really working in an organizational flow that is more palatable and enticing for our audiences to come to. The other thing that we're focusing on this year is standardizing presentations. So we've been working with the medical directors and with Lainey's team on creating presentation standardization for CMEs. And we've done a best practice presentation that we'll be recording for learning purposes and we're in the process of making templates for all CMEs for CPAN, PeriPAN, and for TChat as well, so that it is very clear when we start to present and teach who we are from, and we will have these the same format and flow for everyone. We continue to work on engaging and nurturing our outreach collaborators. So that's like TMA, TPS, all ACOG, and we work and look for different communication opportunities so that the trusted resources can promulgate our messages to their constituents. And we do that by putting communication in their newsletters, by sharing social media posts. At the upcoming summits that we'll be having for CPAN and PeriPAN, we will be looking to some of those organizational leaders and recording some messages that we did in the past as well to be able to share through our channels. Next slide, thank you. So the website, what we've done so far is we had some foundational stakeholder one-on-one interviews. We did about 16 of those interviews. We also audited all of the Access Program websites in the country and looked at in addition to that, we looked at pharmaceutical companies, we looked at health insurance companies, we looked at public health sites to really understand a flow. And then what we did is we presented that in our stakeholder meetings, and also we did active research where we would update the sitemap as we learned so that we continue to get closer to the ideal as we were progressing through those interviews. And now we have a organizational process that we're thinking about. We were able to learn from these stakeholders why they visit the website, what are the highlights of the website for them, what's confusing, and what are their what are their ideas for improvement and their hopes for the website. Next slide, please. So this is where it's small, I know, but this is where we have landed on organization. I think one of the things to note here is that we have repeating categories within the website so that people can enter the website different ways. So if they're thinking, I'm a clinician, they can go and they can look there. If they're thinking, I want to know something about the program, they can go through initiatives and program, and they eventually lead to the same pages, so that people have different entry points. Most of the website pages will have dual entry points for them. We've moved the positioning higher of some of the research workforce initiatives and put in multiple places where we have CMEs, both as resources and then a whole section of project echoes. I'm sorry if I'm echoing. I hear myself. I'm not sure if you guys do, and I don't know why. So apologies for that. Next slide. I'm almost done. The next thing we're doing is the content strategy. So we're working on a wireframe that we'll be presenting soon, and then we'll start writing pages. Again, much of the content is on the site. We are enhancing it as we've done for the past several years working with the program. We now have just tighter brand guidelines. We have tighter language that we use and we have in our content library. So we'll just be making sure that all of that matches on the website. And then we'll also be looking at the visual design and enhancing that a bit. Next slide. That's it. I'm here for questions and comments.
Very good. Thank you, Melanie. A lot of work taking place. I didn't hear you echoing, but I hear you echoing now. Sorry, any questions?
I couldn't quite understand if that was a question. I'm sorry.
I think we took care of the echo here. We had a little echo in this room.
Oh, okay, great.
I didn't hear any echo when you were talking. It was just when we came to this room. But again, thank you for all the work that you're doing. A lot of progress taking place. Any questions from anybody?
Thank you.
Thank you. All right. Rachel, let's go to you next, related to the proposed policies and the promotional items. On this one, we will need to have a vote.
So thank you all for. I'll hear me. Thanks. Thank you all for your comments in our last meeting about this policy, and between the last meeting and this meeting, we did make some changes, which I will go over now. Just a reminder, the purpose of this policy, just to outline requirements and guidelines for purchasing promotional items. We added provider and school recognition items since the last time we met, and staff program attire. Next slide. The key changes since the last meeting, we did add flexibility for HRIs to purchase their own promotional items. In the policy, we state that HRIs can purchase up to 2 promotional items per fiscal year, and those items can be co-branded with HRI logos. HRIs are required to submit mock-ups and price quotes for approval, and when UT System receives those, we will consult with state medical directors or the EM Hub to provide input on that approval. Like the cost ordered promotional items, any HRI ordered item must be $5 plus. We added the mouse pads as an approved promotional item. We also added requirements for resubmission of approval if attire or promotional items change in terms of the type of item, the mock-up, and or price quotes. We also added flexibility for HRIs to use any pivoted items you all currently have in stock. We just asked for you all to reach out to us, obtain an exception from us. We will handle those on a case-by-case basis. Next slide. As I mentioned, we added provider and school recognition items to the scope. So these will be handled a little differently than promotional items. Right now, permitted items include frank certificates for awards. And the state medical directors and the NEOM Hub may recommend additional items to be included as permitted items. We will be requiring a pilot phase for any recognition items to help us determine the effectiveness and ongoing use of those items. So we will ask HRS to provide data to the UT system to help us make those decisions. The providers and school staff who are eligible to receive those items will be determined by the state medical directors and the NEOM Hub. We will also consult with the Center for Health Communication to help us make that decision. And for those recognition items, we did put a cost cap on those $20 or less per item. We increased the total cost limits for items purchased under this policy, given that we made some additions. And then finally, we added definitions for the Center for Health Communications and caution. So as a reminder, here's our timeline. After we prepared the policy, we received the state medical director and NEOM Hub feedback. Then we received HRI feedback. We introduced this to you all in late September, and thanks again for your feedback between then and now. And today we're hoping to get your vote to approve this policy so that we can implement it immediately. Any questions?
Very good. Again, are there any questions related to the revised promotional item policy? Seeing none, I'll take a motion for approval. The second. I have a motion from Dr. Williams.
Second.
I have a second from Dr. Pliska. Any further discussion? Hearing none, all in favor of approval, signify by saying aye.
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 Opposed, nay. Anybody abstain? Hearing none, let the record show that we had unanimous approval for this policy. We're now going to transition to the updates for our various programs, and we're going to start off on our workforce initiatives. And Dr. Pliska, you start off with you.
Great. First, I think there are two kind of from the workforce initiative, two major issues. One is the continuing progress of the LMHA chat pilot. And at our last meeting, we're making some gradual progress, getting protocols in place, some transfer beginning to occur. We have reason to believe those have accelerated over the last several weeks. Certainly here in San Antonio, we successfully transitioned, I think, as many as 4 or 5 individuals from our TChat program to Center for Healthcare Services. We have a follow-up meeting coming here in December, and we'll follow up on that. But the main challenge has been continuing to work out protocols and working with families to make the transition. In fact, I think in general, people transitioning from chat to programs outside of chat can be challenging, whether one is referring to an LMHA or not. But in general, I see good progress there. In terms of CBB itself, all the programs are continuing to progress. We've not had any terminations of any partnerships. People are beginning to ask about forming new partnerships with both LMHA and non-LMHA individuals. So Dave Lynch and I are working on looking at the monthly reports that CBB programs submit kind of really drilling down on those to make sure that hours and FTEs are being reported consistently. And our goal is to kind of develop a more robust way of looking at the overall program, and one that ultimately transition to Salesforce in terms of we're also working with HHSC on being sure that reports of number of patients seen and number of unique patients are kind of being reported consistently across the state, and everyone can access that data.
Very good. Any questions from Melissa? Amen. Thank you. Let's now transition to the child and adolescent fellowships. Dr. Brenner, can we turn it over to you?
Thank you, Dr. Lakey. We should have some slides.
Sorry, Dr. Brenner, I don't think we received your slides. Is it okay if we do a verbal update?
Sure, or can I share the screen myself?
Sure.
Okay. Are those slides visible now? Thank you. So I'm going to cover two things. And also, Claire, are you in the meeting?
Yes, I'm here.
Great, thank you. So I'm going to turn it over to you at some point. First, Claire and I have been finishing a set of initial meetings about what are getting the lay of the land about the other workforce expansion programs. And here you can see the range of disciplines that we're currently being funded and are operational: social work, doctoral psychology programs, meaning programs that lead to PhDs and PsyDs, masters in counseling programs, advanced practice providers, and other medical specialties. I'm going to show you a slide briefly that outlines what's going on in each of these disciplines. What I think is worth our beginning to think about as a group, and I'm just at the very beginning of my own thinking about this, are some of the following questions. One is that most of the programs that we have now have built on existing programs. So things are not equally represented by disciplines. They've tended to depend on what things were going on in the academic departments at the participating institutions. A second question that we're going to be looking about, and I think is going to be fairly low-hanging fruit, is bringing together the people who are all, for example, doing work in social work programs and seeing again if there are opportunities for collaboration. Another question is, again, these have been generated opportunistically by each institution. We might want to think about whether we should have goals or targets for the state by disciplines, and then whether there are things in particular that we want to be encouraging. So I won't go through this bullet point by bullet point, but I want you to all just to get to see something about what's going on across the state. If your own institution, this is directed to the chairs and others, is missing on one of these slides, I apologize. Please send me an email so I can make sure that I add them. But this is what's going on in terms of social work. So that's social work and doctoral level psychology are the most well-represented and widespread programs. Particularly interesting and I think innovative is the program in Texas Tech in Lubbock, which is doing a fellowship that crosses disciplines for LPCs, marriage family therapists, and social workers, because there is a great deal of overlap of what those post-degree licensing requirements call for in terms of supervision. So a lot going on in social work. Also a lot going on in doctoral psychology programs. This is complicated because doctoral psychology programs include funding for student slots in general, funding for specific clinical internships, and then funding for postdocs. So it's a complicated landscape. Also, one of the other things I wanted to mention is you can see on the social work slide that there are multiple funding streams being used to support fellows. In other words, some, when we surveyed this, some are being funded completely through the other workforce expansion funds, but also have other funding streams from TCHAT and CPAN, et cetera. Again, here I'd highlight Baylor, which is the only one who's actually looking at creating a new clinical psychology PhD program. So that's quite exciting to see. Advanced practice provider fellowships, not as much going on across the state. We have 2 slots at UT Southwestern. Again, building the advantage of building on existing programs. There is already a centrally run at UT Southwestern APP fellowship infrastructure that we were able to add on to. And UT Health Science Center in Houston is considering creating a mental health nurse practitioner degree program at their nursing school. That, again, quite exciting. Master in counseling programs. Here, I want to highlight something I was just particularly impressed with, which is the San Antonio program. The San Antonio program is called the We Care Clinic. Not only is funding trainee slots and supervisor slots, but doing this by creating a clinic to take care of the referrals generated from the other TCMHCC projects. So I think quite innovative, focusing on training people in parent-child interaction therapy, an important evidence-based approach. And there are 2 kind of other medical subspecialties at UT Southwestern are being funded, a Women's Mental Health Fellowship and Developmental and Behavioral Pediatrics. So that's just to give you all an initial sense of the lay of the land and the complexity of what's going on in the other workforce expansion. Next, in terms of the Child and Adolescent Psychiatry Fellowship growth, one of the things that Claire has been leading us on is in developing a description of what the pipeline actually looks like that generates, in the end, new child and adolescent psychiatrists. Claire, can I ask you to step in here?
So the CAP Fellowship Leadership Group has decided to look kind of visually at the pipeline to really identify where the group might want to work together and what gaps the consortium might be able to fill and for different intervention points. So this is just a very simple visual depiction of kind of that timeline or the pipeline, starting from high school, going through undergraduate, into medical school, then psychiatry residency, and then ultimately into a CAP fellowship. And then on the next few slides are just some examples of the different pipeline phases. A brief overview of the current landscape here in Texas, a couple of already identified gaps from the conversations that have occurred in the leadership group meetings, and then a couple of considerations. So on that far right-hand side, a list of prompting questions that the group can start to consider and brainstorm through for each of those phases. Just kind of get that brainstorming going. And hopefully leading to some identified ways that the consortium can work together to support that workforce pipeline.
Thank you, Claire. Much appreciated. As is your partnership in this process. That's it for us, Dr. Lakey.
Yeah, any questions, Brandon? I guess one thing that I would add, and Elizabeth may want to add to this, but the Texas legislature put in a significant amount of additional funds for general graduate medical education. A lot of focus on primary care, in which psychiatry residency is included. The due date for those applications, Elizabeth, correct me if I'm wrong, is January 12th. And so
Yes.
if you want to increase the number of general psychiatry training slots, go to the Texas Higher Education Coordinating Board and pull down the information on how you could put in an application to be able to expand the number of general psychiatry programs. Elizabeth, did I get anything wrong there?
Nope, that was perfect. If you have any individual questions, please feel free to reach out to me and we can connect and talk about any eligibility. But if you go on our website, it's pretty easy to find. But if you have any challenges finding the RFA and the details of what's required, just let me know. And as Dr. Lakey mentioned, the program was about $233 million in the prior biennium, and it bumped up to $304 million. So there's a continued investment by the legislature. And so I think we want to expend all of those funds. So if you have any questions, please feel free to reach out.
But let me ask a question while we have you.
Sure.
There are now an increasing number of programs that match residents into general psychiatry and child psychiatry at the same time into an integrated 5-year plan. Are these funds eligible for those programs?
If they're an expansion or
yes,
like if their ACGM numbers are increasing, if those numbers are increasing, not knowing all the details, I would think they'd be eligible. But Dr. Brenner, happy to have a separate conversation as well with you.
Thank you.
Mm-hmm.
Dr. Ibrahim?
Dr. Ibrahim, we've been, I don't know if you can hear us, but let me go to Dr. Amador first and then come back to you. Amador?
Hi there. Good morning, everybody. I just wanted to put it out there that at the 2025 ACAP meeting this past October, there are talks about a group at ACAP is working on proposing and making child psychiatry its own specialty, meaning that you wouldn't necessarily have to go through general psychiatry residency. So there are people looking into maybe that way might be another avenue to get more people interested into becoming a child psychiatrist. Because I think they had mentioned that last year they had applied through ABPN to do a pilot program to cut down a year or so of training. But their original application was denied by the ABPN, and they were recommended to maybe explore having child psychiatry as its own separate specialty. So just putting that out there.
Very good. Any other comments? Dr. Ibrahim, looks like you're trying to reach us, but maybe having some technical issues. We come back around to you in a little bit. If you want to ask.
Oh, I shouldn't have had my hand up. I'm gonna lower it down.
Very good. All right. Thank you. Any other questions? Very now again, thank you, Adam. And thank you, Elizabeth, for letting me put you on the spot there. Let's go to Dr. Wakefield and the update on period plan.
All right. Hi, everyone. I'll just wait. We haven't looked. Oh, there we go. Wonderful. All right. Great. Next slide. So we continue to see some increases in enrollment, now over 1,200 obstetric clinicians in the state of Texas. And then we have a variety of other clinics that we include as well that aren't on our state metric reporting, but we want to make sure that everyone knows that we are recruiting and we are enrolling people, other types of obstetric clinicians and not just OB-GYNs. Next slide. I think want to mainly draw your attention over to the monthly consult volume. We had our highest peak rate in July, but since July, we haven't quite gotten all the way back up there, but we have maintained higher than we had seen the rest of the month. So we're really excited that we continue to see some increase over time in our consult volume. Next slide. We still continue to have physicians as our number one caller, about 50% of those calling, more than that when you include our resident cohort as well. Next slide. So these are the total consultations by month and calendar. So you can kind of see a little bit more of what I was saying in that first slide, that although we had this huge peak in July, which we were really excited about, our subsequent months, despite not being back quite to what they were in July, are still higher than we've had ever in the past. And so if we hadn't had that July, we would continue to see an upward trend. And we haven't seen in peri-pan so far the cyclical nature that we see in child psychiatry that we see across our programs. So we'll continue to look for trends, but we just continue to see increased call volume, which we're excited about. All right, next slide. This is our slide where we talk about, we'd really like to see at least 33%, at least a third of our consultations going to psychiatry. When we look at other statewide programs, that seems like what they see. 2/3 sometimes can be handled by another clinician besides a psychiatrist, but we want to see at least a third. We have continued to have much higher rates than that in peri-pan, which we are very excited about. Has seemed to be decreasing over the last couple of months, and so we'll work in our one-on-ones with teams to see what that change has been. We want to make sure the clinician's call is handled as efficiently and effectively as possible, but we know that the driver, one of the main drivers of the change behavior for our obstetric clinicians or our pediatric clinicians for that matter, is talking to the psychiatrist, and that we're not just here to answer the exact question that was asked, but we're here to understand the context around the question and provide as much education as we can, as succinctly as we can, to motivate a change behavior and motivate increased capacity or support increased capacity for that frontline clinician. So we're still way above that 33% mark that is our baseline target, but we have seen some downtrends in the last couple of months. And so we'll work with our teams to make sure we are transferring as many calls as are appropriate to the psychiatrist, so that we make sure we get the biggest bang for our buck in that phone call in increasing change behavior and building capacity in our frontline clinicians. Next slide. All right, so these are our direct patient consultations. This is when we're actually seeing a patient. One of our reproductive psychiatrists is directly seeing a patient to better understand the diagnosis and provide next steps in care, and with the ultimate goal of trying to retain that care still in the frontline clinician's clinic. And we continue to see much higher volumes of these than we had in the past. So I am so appreciative of teams coming online to provide these direct patient consults. I also, the more we get, the more we see that these are triggered by the conversation between the reproductive psychiatrist and the calling clinician. And so we know that if we can get to this point, we're able to provide a very high level of expertise and recommendations to that clinician, and very specific recommendations for the woman. So we are excited that we continue those at a higher level. Next slide, or higher frequency. This is a question that we have gotten over time, and so we have split it out. And that I had said about 50% of our callers, if we're just looking at non-resident physicians, are physicians, and then when we add residents, a much higher percentage than that. We continue to see obstetric clinicians be our highest caller, followed by residents, and we'll be able to split those out into the resident type in the near future is a goal that we have. But the physician type calling for peri-pan consultation, the next most frequent after obstetricians are pediatricians. We know that our pediatricians have high requirements and mandates to screen moms in that first year postpartum, especially the first 6 months. And so we do see pediatricians calling us, which we're excited about, so that we can provide some guidance there. And then our next most are our psychiatrists. And then we are seeing an uptick in our family medicine doctors. So we're excited about that. We want to increase that. We know not all family medicine doctors across the state are providing obstetric care, but we know a lot are. And we want to make sure they are aware of our program and that we are providing them our consultation whenever is appropriate. So next slide. These are things what peri-pan has been up to since the last time we met. We have been working with HHSC and to try to increase the rate of calling and try to understand what is working well, what is not, and really get information out to our obstetric colleagues across Texas. And so I did several presentations over the last few months called Peri-Pan and You equals improved outcomes for women in Texas. And we really looked at the current state of perinatal mental health in Texas, identified strategies to screen and assess symptoms, and then discussed how to incorporate Peri-Pan to support. In that process, we developed a pocket card that really mimicked or really represented the cut scores in our toolkit. So we were able to present our toolkit and all of the resources that are housed in that toolkit, and then provide a pocket card also to the obstetricians that they could keep with them more closely. That was a recommendation from one of the obstetricians. We're really excited about that. We have distributed those pocket cards not just in those presentations that was a collaboration with HHSC, but also during the ACOG District 11 Council and Junior Fellow Council meeting that occurred in October, where we were able to tell them, do a similar presentation, talk about the toolkit, talk about the pocket card, and get that to them. What was really exciting about that is that it was at a previous ACOG meeting that I was approached, a District 11 ACOG meeting. Texas has its own district since we have so many obstetricians here. And it was in a previous District 11 ACOG meeting that I was approached with this idea of doing a pocket card by an obstetrician. And so we were able to work closely together and really respond to their needs, which was great. Throughout this HHSC collaboration, we've also heard from obstetricians about different things that they think would be helpful to them in implementing the toolkit or getting resources more accessible for them to utilize and get out to patients. And so we've been able to respond to those as well and work within our team. So great full circle moments that are coming out. We've also, in the last month, had a presentation from Dr. Marlene Freeman, just to make our clinicians aware of some opportunities to support women who are taking medications during pregnancy, and to refer them in case they are interested in providing more information about that. There is, it's very hard to get information about postpartum psychosis because it's a quite infrequent event, and there's some work going on nationally to try to better understand postpartum psychosis. And so we wanted our clinicians to be aware of that, and to make that opportunity aware, or make their patients aware of that opportunity if they so choose. Next slide. So what are we still doing? We're still working with Pathways through the PCORI, and in the process right now of assigning participating PeriPan hubs to the 12 obstetric clinics in Texas that have agreed to participate. As a reminder to all of you, or those of you who are new to this discussion, we are working with the Lifeline for Moms team through a PCORI project to try to increase our technical assistance, or really helping the clinics understand when to call PeriPan, what PeriPan can do for them, try to increase the amount of just awareness and education and utilization of PeriPan by helping clinics know when to screen, when to refer, when to call. We've also been working with amongst the entire COSH team and our participating HRIs on Wellnity improvements. And that's just the resource database that we have, trying to make sure we have accurate information in there that's as easy to access as possible. We've been working, as you heard earlier, on HB 18, collaborating with the UT system and other stakeholders to discuss how to implement these projects with rural hospitals. We have worked with Be Well Texas on our maternal mental health and substance use disorder ECHO series. That's what that very long acronym is there. And so aligning our ECHO series project with Be Well with the webinars that we have. And so we concluded our 2025 series in December, and now we are launching into our 2026 series starting in January. I'm sorry, we actually concluded that totally in November. We are attending, or about to attend, the District 11 Texas Residency Program Leadership Roundtable. I have been working with, presented to this group before, of our residency directors across Texas for our obstetric programs, and how we can better support our obstetric residents and residency training directors in the resources that we already have. And then working with trade improvements for our clinician portal that will be launching, or that is launched and in beta. And then also working on measurement-based care for our direct patient consults. Next slide. This is just a little bit of feedback on the clinician portal. We're really excited about the clinician portal. I think Dr. Williams will talk a little bit more about it. But we launched our initial with our high utilizers so that they could give us some feedback on October 17th. And some of that feedback was that the portal was very helpful for timing. I was able to complete the request at a time when I wasn't available to talk, but could schedule the request for a convenient time. It's a great way to reach out for assistance on your own timeline. We think that this will be very, very helpful for all of the clinicians across our access projects and CPAN and PeriPan, but I personally feel like it will be very, very helpful to our obstetric clinicians who will be able to put in consults and really give a lot more information than they are able to, or maybe feel comfortable with in a message, and then request a time to call back when that's outside of, when they're running around between clinic and deliveries and all of those different things. So really excited to launch this in full, and how it will increase the convenience to our clinicians. Next slide. I think that may be it. I think that's it. Yes, happy to take questions.
Good. Any questions? Seeing none, thank you again, Dr. Wakefield. Let's transition, Dr. Williams, to you for the update from COSH and for CPAN, and then for TChat.
Waiting. Yay, somebody's doing the slides. I love it. Can you hear me okay, Nava? Is it working? Okay. I was told to be projecting. Sure. So we're talking about CPAN first. The same slide you saw in PeriPan, you're going to see with CPAN. I just want to point out here how quickly we continue to be able to provide help within 99% of the time within 3.5 minutes. or less is when we are getting calls back. So when a physician or a nurse practitioner or whoever is calling us says, I need you to call back in 30 minutes, we're doing that 90% of the time. So very exciting that we continue to grow that high level of when I need it or who we need it. Physicians can also though request what time specifically they want this without outside of that window, but we continue to pay attention to that because we know how busy first primary care doctors are. Next slide. This is the same slide we saw with PeriPan, which will be specifically at CPAN session. As you can see from year to year, we continue to see an increased growth in our total consult volume, which we're very excited about. And next slide. Actually, if you go back to the slide, I didn't want to skip this. We had our highest call volume today in October with these big zillion calls. So I think it's
over 1,800 calls.
Yeah, it was close. I was right, but the zillion is close to that. But 1,800 calls, right? So once again, we continue to see that seasonality that Dr. Baker was talking about with children's mental health. There's always dips in summer and the fall rate. But despite those dips, we had our highest call volume in October. So really a lot of great work. We're very thankful for all the teams and all the hard work. The next slide. That is the slide we're talking about where we're trying to get at least 30% of our calls going to our physicians. So we have a physician to physician conversation, as you can see here. We're kind of between the 36 and 40% range over the last quarter, which we're pleased to see. Next slide, and the direct consultations that we're doing similar to PeriPan, we do have occasions where the consultation request really does need us to actually see the patient for that PCP and sort of helping, a good assessment and then allow them to have a better maybe plan to move forward to continue to care within their primary care office. And so we continue to see a pretty nice volume of direct consultations month to month. Next slide, as Dr. Wakefield alluded to, we have had our launch of our PCP portal. This is another way for providers to reach us within a portal. So right now, you can call us, they can text us with no contact information and just, hey, can you call me back? And now on the portal, one of the things that will be really fabulous, I still remember my dad as a family physician at 7 o'clock at night, in front of the TV, watching the Cowboys and doing his notes. So a lot of physicians are doing their sort of charting and other kind of work for families after hours. And so being able to, have the computer open, you're doing your EMRs, I would say nonsense, important stuff. And be able to go, oh, I forgot to call TCAN or PeriPan today. Let me do that real quick. Let me put in my request. So we're really excited to have launched the portal. And that, as Dr. Wakefield says, we want to start with users that we had a good sense that they would use it, so we can get some good feedback from them before we consider when we will do this. Let's say statewide launch to over 15,000 providers. We wanted to start with a smaller group, make sure that the portal is really functioning the way we want. Within that portal, we do have these additional functionalities that go above and beyond just putting in your requests, which we're very excited about. They will also be allowed for us to share documents. So we'll be able to share our resource list through a secure portal. Once we have the direct consultation completed, they would have it sent in a secure fashion. And so they can put in their own EMRs as they would like, or in their own paper charts if they would like. And also what Dr. Wakefield and I are very excited about is being able to help them with measurement-based care. So when, for example, we do a direct consultation, we ourselves will be using measurement-based care to do some screening, using screening tools, but we ourselves, if we do a Dr. Bliska, he said, start people, whenever he is talking to a PCP, he could say, hey, you don't want to do the Vanderbilt with this person to determine if they have ADHD or not. He could then send that Vanderbilt, and that Vanderbilt could then go directly to a family on behalf of that physician, that PCP. So we're really excited to be able to expand that measurement-based care process out to ensure that we're doing good assessments of young people and women. So these are just the things that are available in the portal, separate from just being able to put your requests in. Next steps, like I said, we are reviewing that feedback. We hope to kind of in the next several weeks get a little bit more utilization from our team, our providers across the state. And then once we felt like we've gotten sufficient feedback, then we're going to coordinate with UC System and CHC and communications and our teams to develop will be our rollout for those 15,000 plus providers. So we'll be talking together. My hope is sometime in the first quarter, we'll finalize a plan with all of our stakeholders and then start deployment out across the state. Next slide. Again, the feedback that we have gotten is it's been overwhelmingly positive today. I'm not going to read this to you, except to say it's an easy fit, easy, quick to use. That's one of the things we're trying to pay a lot of attention to. As we know, physicians and providers are extremely busy. Sometimes they can feel like there's just one more thing I have to do in a day. So our job with CPAN Period is to try to make that be as easy as possible. And with the portal, again, having those document shares, they start to generate their own little library of material that they find helpful to help them in the care of patients and children and women. Projects that are in process, we are collaborating with HRIs. We'll be improving the dashboard now. We are so busy. We discovered there's some things we want to improve about the functionality of our team's dashboard as they're taking those calls, doing those direct consultations. We also have been working on a resource library that's separate from the referral library. This is resources that are designated by disorder. And so it includes what would be a resource to give to a primary care physician, what would be a resource to give to a patient, to a child, what age the child is. We asked for state experts across Texas to help us ensure that whatever resources we're putting together are really the most evidence-based resource available and up to date. And so we've been slowly but surely walking our way through our various top sorters and have a increasingly extensive resource library. We're currently reviewing our autism educational resources, and we're getting information from our subjects experts across the state related to that. As Dr. Wakeman says, we're working on those mobility improvements, HB 18, and we have worked. This year was the first year we've had state funded CPAN and CPAN webinars and echoes. Before it was all 12 teams doing it themselves. This is the first year we've come together to bring it all as one. And we're getting our last fall echo webinar was just I think last week or so. So in December January we'll have data on the source of volume. And that's all for CPAN. Teacher. The next slide you can see here is our normal slide looking at those referrals from month to month, from year to year. And certainly this year we've had a little bit less growth in the overall total number of referrals, but it still is a bump up, and that is partially because we have done a really awesome job across the state of getting all the school districts in the state that would like to participate to be involved. And so now the next thing for our teams to be doing is not just having somebody have an MOU with us, but really encouraging the utilization of the chat service. Obviously, a large school district, such as Arlington ISD or other big ones like within the Austin region, they might send us a lot of referrals, because they're just bigger by population base. We want to make sure that rural schools, often if they have smaller numbers, they sometimes have a greater need to make sure that they know about our program and are sending us referrals so that we can assist those children and families. Next slide. What we're pleased to see is that our enrollment from referral is staying also really high. And so again, referral does that. A family has consented that the school can send us information about their child, but we will not move forward with seeing a young person until we can speak to that parent or legal guardian. So then from a referral, we also must have an involvement where a parent or legal guardian says, yes, I would like for my family to participate in TCHAP. So we're excited to see those enrollment numbers also remain high for later here. The next slide is a familiar slide for you is the number of young people is in that red line, as well as the total number of sessions in any given month. And again, we continue to see nice steady volumes. We always have that summer dip because schools are out. I was going to remind us every single time, although you get bored of it, do it unless, is that even during summer when schools are closed, TCHAT is still open and we're still processing referrals and we're still seeing patients. So the numbers dip, but it's not, we're closed, it's just schools are closed. And the next slide shows you the type of provider that is seeing those young people. And again, because in children and adolescent mental health, the most important type of tool that we have is an evidence-based psychotherapy or psychosocial intervention. The vast majority of young people are seen primarily by a therapist. Therapists can be of different types. They can be LSW, LCSW, LPC, psychology, sometimes psychiatry does do therapy. There's a number of different people who are therapists, and you can see the vast majority of our patients are seen and treated by a psychotherapist. When needed, obviously with parental approval, psychiatry does get involved for the cases that are a little more complex, maybe treatment resistant or have a disorder that first line of treatment includes a medication. Next slide. One of the things that we really have been very focused on is sort of outcomes and measurement based on them. And so we've been working with our data management system along with UT Communication and Laney and the CHC to develop additional ways to remind families and young people to complete the assessments that are sent to them within our treat system, so that we can ensure that we are getting some data that is more quantitative. It allows us to kind of improve our assessment of the young person and then track over the time that they're in our service, how we're doing. And so we have a really high percentage of families returning the initial assessments in once we did the first layer of automation. And now we're hoping with the second layer of automation after that first visit that we will see the numbers also for the return appointments increase as well. That'll really allow our clinicians to work collaboratively with families to ensure that if we're really working to help Sally's anxiety, we are using measures to see how Sally's anxiety is doing, and if we're seeing improvements, great. If we're not seeing improvements, it allows us to have sort of more pointed conversations, decide what intervention we might need to improve or change to make anxiety treatment even more better. It's not very good, but more effective. Sorry, direct teachers help there. But make their treatment more inclusive. So we're really excited to have that process. So there's a lot of very customization within that automation because there's 12 different HRIs, the logos, they use eyes and cross, and she's reminding me to remember how many emails did you have to look at? Like 100 or something, it was a lot. So there was a lot of things we had to look at the details to make sure that those assessment emails look good. So we're happy for that. Projects that are in process, we are working on a presentation work group to have a library of sorts for presentations to school counselors, school teachers related to youth mental health concerns. We're collaborating again on HB18 for TCHA, and we're continuing to work on the implementation of integration with our data management system with EHRs, as well as the LHMA island that Dr. referenced. So always doing something, I guess is the best way to say that. And that is, I think, the last slide.
Very good. Any questions? Dr. Williams? Seeing none, why don't we transition, Rachel, to the governor's report, the data that we provided the governor's office on TCAT.
While it's loading, I just want to thank the internal evaluation team for preparing this data for us monthly. And I know it's a lot to handle of the release of the data and excited to see our progress. So this is data as of October 31st. We are continuing to make slow but steady progress on active campuses. So we are currently at just about 79% of all campuses covered. That represents 82% of the student population in our state. We have 140 campuses still in plan status. So we'd like to see that number get down to 0 here over the next few months. Next slide. We have a number of schools with planned implementation dates. You'll see that a number were planned for implementation in November and a big batch of planned for the rollout in January. Next slide. We saw increases in active campuses in 6 education service centers over last month. Here you can just see the growth continues. Slide. And finally, reasons for decline, the largest, the number one reason continues to be that the campus has existing mental health providers. Any questions?
Any questions from anyone? Yeah, thanks to everyone. Again, significant growth, still 82% of the kids in the state of Texas now have T-Chat available to them. Possible without doing great work that you guys are doing across the state. Okay, let's move on then, if there's no questions, to on the last section of our agenda. We're going to have some updates on the evaluation of the programs, and we're going to start off with what we call internal evaluation in our customer relations management system. Cynthia, are you there?
I am, yes, Dr. Lakey.
Very good.
All right, hello everyone. I'm going to provide a brief verbal update on the status of our CRM implementation. We are continuing to use Salesforce to manage T-Chat MOU status and outreach and training activities. It has been about 8 months since we rolled out the platform. Engagement is high and end users do seem to find the platform easy to use. Several enhancements and improvements have been made over the last several months. These improvements and changes have been made based on user feedback and then additional requirements from UTS. I mentioned in an earlier update that we rolled out the staffing app at the beginning of this fiscal year. The staffing app is being used to manage employee data such as new hires, when someone has left your org, FTEs, and also program assignments. As a reminder, HRIs are responsible for maintaining up-to-date and accurate employee records in Salesforce. This is important not only because UTS needs an accurate headcount, but also because other processes are based on that employee that we have in the Salesforce platform. So for example, when a new employee is entered into the database, that triggers UTS to open up access to other platforms such as SharePoint and Trait. So if you have a new employee who says, I still don't have access to SharePoint, it could be because their new employee record has not yet been created in Salesforce. So please remind your staff that expectations are that employee records are entered and updated in real time in Salesforce. In addition, beginning in September, HRIs were tasked with entering positions and vacancies in Salesforce. Those are your job openings. As of today, roughly half of the HRIs have entered that information, so that is an outstanding task for your teams. Within the staffing app, we're also tracking employee allocations. That's something new that we implemented this fiscal year. And employee allocations refers to the percent of time each staff member spends on consortium-related projects. Allocations are being verified quarterly within the system, and the first round of allocations, which are our Q1 allocations, are due by December the 15th. So again, another outstanding task for your teams. We are now moving into our next phase of development, which will include CPW reporting, which Dr. Pliska mentioned earlier, as well as a new custom app for CPAN and PeriPAN data. That CPAN and PeriPAN app is going to include provider lists, enrollment statuses, and also clinics. HRIs were tasked with validating and approving the provider data prior to upload into Salesforce. I know that was a big task and a big ask for your team, so thank you to everyone for taking the time to review and approve that data. And then finally, we do plan to have the app ready for demo during the CPAN PeriPAN Summit in February. Right? That is it.
Any questions? Hearing none. And thank you. And let's move forward on the external evaluation for CPAN T-Chat survey findings. Dr. Salas, Dr. Haskin?
Yes, I'll start us off. Can you hear me?
I can.
Oh, great. Okay, so we're going to share results from 3 major surveys that we conducted in 2024, the fiscal year 2024. And these surveys engaged over 400 CPAN and T-Chat stakeholders, including providers, school staff, and parents, to understand the barriers to program engagement, assess satisfaction with services, and highlight practical strategies to strengthen engagement and implementation. So the overall goal of the CPAN survey conducted among providers enrolled in CPAN was to understand the barriers and facilitators to engagement, to inform program improvements. For the CPAN provider survey, we focused intentionally on providers who are enrolled in CPAN but have never used the service or who haven't used it within the past year. So surveys were conducted September through November 2024, and we received responses from 138 providers with about 59% non-users and 41% non-recent users. Here you can see some of the key findings for future engagement potential. It remains very strong. You can see across both groups, 84% they intend to use CPAN in the future, which signals substantial opportunity for growth, even among clinics that have not yet integrated CPAN into their routine workflows. Reasons for non-use highlight communication and system challenges, not necessarily dissatisfaction. The most common reasons for never using CPAN were practical and reflective gaps in awareness and onboarding, rather than concerns about the service itself. So you can see 25% of non-users didn't know how to call CPAN. 17% were unaware they were enrolled. 25% felt unable to manage patients' needs independently. And 24% believed they were able to meet the needs of children with mental health issues using their existing resources. Among non-recent users, discontinuation was frequently tied to the structural factors like existing integrated behavioral health services or lines and internal resources. This shows, again, that the lack of use was not a reflection of dissatisfaction. So despite limited use, providers clearly recognize CPAN's value. Providers consistently identified CPAN as beneficial for medication management, where 73% supported that. 73% said it helped them increase confidence in treatment decisions. 69% reported diagnostic support, and 68% satisfaction with the assistance with appropriate referrals. So to just think about the barriers that reflect clinic factors and program-related factors to improve on, providers cited several challenges that limit their ability to use CPAN. 47% noted clinic time constraints. 37% reported limited awareness of enrollment or how to access the service. 23% felt that CPAN does not fully meet their needs, and 22% noted limited buy-in from colleagues. And together, these findings point to a need for program improvements to improve onboarding, improve communication about what CPAN offers, and potential to add support for integrating CPAN into routine practices, such as through increasing training for clinic champions or training clinic champions and consistent workflow reinforcement. In addition to these program improvements, our findings do support that high satisfaction among those who previously used CPAN. So for non-recent users who had called CPAN in the past year that we included in the survey, we found strong satisfaction with the quality of clinical expertise, responsiveness of consultations, and usefulness of CPAN's guidance and resources. Satisfaction was mixed for continuing education and training opportunities and lowest for the referral directory, which many providers felt needed improvement in accuracy and easier access. So these findings highlight a need or opportunities to improve strategies to enhance provider and clinic engagement, such as, again, strategies that can be used at orientation to increase awareness of CPAN resources, and also increase awareness of continuing education opportunities for enhancing engagement there, and for increased opportunities to communicate the referral directory. Again, I'll underscore also that because this was in 2024, we know from our current survey results also more recently that we're analyzing now and analyzing, a lot of these areas have also been addressed since the survey. So next slide, please. So this slide summarizes provider feedback on strategies to strengthen CPAN implementation engagement, drawing from the what we call the ERIC strategies, which stand for expert recommendation for implementation change. And this is from an implementation science heuristic. And it's a taxonomy of implementation strategies that are commonly used. I can't quite say they're evidence-based yet, but they've been identified by experts as commonly used, especially in schools and clinics. So we surveyed providers on their perception of what would be helpful to support engagement or implementation, integrating a lot of these strategies into the survey. So first, providers emphasize process-focused supports. So the highest endorsed strategies included for billing support and help identifying and addressing implementation barriers, both at around 2/3 of respondents. Many also value toolkits or program guides, reminder systems, and technical assistance. These findings point to the need for opportunities to clarify what exists, create new supports, increase accessibility of tools that help clinics integrate CPAN smoothly into their day-to-day workflows. And program integration is an area that we've been seeing come up again in other evaluations. Second, relational and engagement supports were also highly valued. Providers responded positively to wanting opportunities for peer sharing around mental health needs. The presence of clinic champions and dedicated time during staff meetings to discuss CPAN use. These strategies reinforce that provider communication and internal champions may play an important role in enhancing engagement, supporting implementation, and sustaining CPAN. On the training and education side, providers expressed interest in additional CPAN trainings, specialist-led sessions, opportunities, share best practices, and more interactive formats. And finally, leadership engagement also matters. Nearly half of the respondents said that having leadership explicitly declare CPAN a priority would help reinforce its importance and increase broader clinic level buy-in. So together, these findings help identify some potential strategies to improve implementation, underscore continuing building on these strategies that already exist and can be enhanced, and flag that a combination of practical tools may also be supportive in enhancing engagement, as well as consistent communication strategies, peer support, and visible leadership endorsement to promote stronger and sustained system. And that's a really brief with synopsis of our survey findings. That will bring a more detailed report. And I'll hand it off to Dr. Preston, who will talk about the chat background survey findings.
So before you do that, Dr. Wakefield has her hand up. I wonder if she
Sure.
has a question she can answer right away. Your response up.
I just thank you, Dr. Savas, for this presentation. I was just wondering if you knew what it meant, if you were able to collect any additional data on more interactive education and training formats and what that meant. Because if we could understand the difference, we have webinars and echoes and those things now. And thank you.
Yes, and we do have, maybe what we can do is flag it, because we do on surveys like different formats. And it's just so much detail to include in 2 slides that we couldn't provide it all, but yes. And also these survey findings helped us also develop the next survey so that we could get more information on that. So that is a really great question. And another reason we were kind of doing this. We also have qualitative and open-ended findings that we analyze. So we can, even if one person mentions something, They usually represent a group, a larger group in qualitative research. So we'll share that with you also so that you can get all those results.
Thank you. Thanks.
Any other questions?
Okay, can you all hear me? Okay.
Yes, we can hear you. Good.
Okay, great. So I'll focus on the TCHAT survey findings. And so for the TCHAT school staff survey, this was conducted last year in May of 2024, and then we went back after the summer and collected additional information from respondents in September of 2024. And so just like with the CPAN survey, we focused on campuses that had enrolled in TCHAT but have never used the program or have not used it in the past year. And we surveyed a stratified sample across all 12 HRIs, and we received responses from 140 school staff, which exceeded our target. So overall, nearly all of the non-users and non-recent users indicated that they intended to use TCHAT in the future. So interest remains extremely high. And we think this recommends, this indicates a strong openness to engage with the program. School staff continue to view TCHAT as highly valuable, and they consistently emphasized the fact that TCHAT provides free, convenient mental health care that students might not otherwise access. And this was especially important in districts with limited mental health resources or long wait lists. They did note some barriers, which included the fact that they felt that the telehealth model did not work for all students, either due to age or behavioral needs or just difficulty engaging virtually. They also noted barriers such as limited parental interest or lack of follow-through, a lack of space at school, and then challenges completing referral or consent forms. And this is really consistent with patterns we've seen in prior years, and really highlight the importance of just continuing to focus on our processes and trying to simplify them and strengthen parent engagement. The non-recent users, so those that had used it in the past but not in the past 12 months, also reported high satisfaction overall, with the strongest ratings for referral training, service quality, and processing time, and then moderate satisfaction with HRI support and communication. And common challenges included obtaining parental consent, time and staffing constraints, and then limited provider communication and follow-up. So overall, these findings, show that schools value TCHAT and want to use it, but may need streamlined administrative steps, continuing to focus on parent-facing supports and stronger communication structures to really fully engage. Next slide. So we also asked the school staff about using the ERIC strategies that Dr. Savas just mentioned again. And this slide highlights the strategies that school staff felt would be most helpful to support TCHAT implementation. And so first, the staff really emphasized the need for strong implementation process support. So top priorities included clear supporting materials and toolkits, increased support for the TCHAT campus liaisons, and then also help identifying and addressing barriers. Each of those were endorsed by at least half of respondents. Staff also valued having a list of common terms and definitions, reminders to refer students, and systems to deliver technology assistance, which can help schools, navigate the telehealth logistics. And then technical assistance from HRIs was also endorsed by a smaller proportion, but still identified as helpful. Second, communication and awareness strategies were also endorsed. So staff placed particular emphasis on strategies to encourage parent participation. They also noted that marketing materials for parents and the broader community would be really helpful to help families better understand and trust the program. There were also strategies endorsed related to training and education. So staff requested more educational sessions for parents, as well as additional school staff trainings to build comfort with the TCHAT processes. Again, we also saw the note about more interactive training formats and opportunity to hear from other TCHAT users, which again really reinforces the need and value of peer-to-peer learning. And then finally, relational and engagement supports also play a critical role with adoption. So the highest endorsed relational strategy was being able to share program outcomes with schools. And 75% of staff indicate that that would really help build confidence and buy-in. And then they also endorsed and valued opportunities related to sharing best practices with other schools, having time to discuss TCHAT at staff meetings, and then having TCHAT be declared a priority from school leadership. So really having that visible support from the school leadership was really highly endorsed. So next slide. So we also did a survey with TCHAT parent and guardians, and we really focused on understanding families' experiences with the program and their perceptions of service quality, cultural responsiveness, communication, and their perceived outcomes for their child. So we received surveys back from 128 parents or guardians, and this was, and we received representation across all HRIs. Key findings was that parents consistently emphasized how accessible TCHAT was. Nearly 70% said that TCHAT was more convenient than other options, and almost half reported that they could not have accessed the care elsewhere due to cost. And so we felt that this really reinforces TCHAT's role in reducing major access barriers for many families. Convenience was also a major theme throughout the feedback. The parents really valued the convenience of having the sessions directly through the school or virtually, which really helped to eliminate travel demands and made it much easier for working families. Satisfaction was exceptionally high. Parents consistently rated the quality of care favorably and felt that providers communicated clearly with them, kept them informed, and supported them throughout their child's participation in the program. And almost all parents reported meaningful improvements in their child's emotional and behavioral well-being. And I think that is the last slide. Oh, one more slide. Parents also described TCHAT providers as respectful, compassionate, and attentive to the family's backgrounds and values. Some families did experience, or they did indicate, challenges with technology, paperwork, and navigating referrals. So kind of reflected some of the findings we saw with the school staff. Follow through on ongoing care varied due to access barriers. Some parents requested smoother transitions and longer term support, which we know has already been addressed. Families have also asked for more flexible scheduling and additional in-person or hybrid service options. So next slide. That's it. So thanks so much.
Very good. Any questions? Any comments? A lot of good information there. I guess the one that kind of stuck out to me was that parent survey for TCHAT. And I may not have the data exactly right, but about half the individuals there said they wouldn't have gotten care otherwise without cost, and that they were overwhelmingly supportive of the quality of care that you all provided. In a nutshell, I think that's what I heard, and that's a reassuring quality of the program right now. Any other comments?
Great job, team.
Job team.
Well, thank you all to everybody who helped participate and all of the assistance. So we really appreciate it.
With that, I think we're at the end of the agenda. And so again, thank you for your time today for this meeting, but the time you guys have been putting in to provide this kind of quality program. Thank you to all of our presenters, and we'll talk to you after the holidays. So happy holidays, Merry Christmas, Happy New Year, and we'll see you soon. Thanks.
Happy New Year.
Thank
Bye.
you. Happy New Year.